I am Bilavel from the University of Arizona, and I'm here to present a case that is titled The Mystery of Dermatitis in a Young Female. So we came across this 36-year-old female who presented for evaluation of a pruritic maculopapular rash. On history taking, she mentioned that this was a chronic intermittent rash that started in her teenagers and occasionally flared up like 5 to 6 days before her periods and had some improvement after her periods. So the thing was that her periods were pretty irregular and she wasn't able to give us a very good history about it. So she also mentioned that she had incomplete response to antihistamines and topical steroids. Her past medical history was significant for severe migraines, polycystic ovarian disease, and seasonal allergies. She was a non-smoker and denied any alcohol use or illicit drug use. So on examination, she was widely stable. Her lungs and abdominal examinations were normal. On skin examination, however, I noticed that there was a diffuse maculopapular rash on the upper and the lower extremities, as well as her abdomen. And here you can see the picture of that rash. So for the rash, we decided to do a comprehensive workup. We ordered a bunch of labs. We began with the CBC and stuff like that. So the CBC came back negative. It was all clear from that end. Her IgE levels were slightly elevated. We also did a hepatitis workup and a RPR to rule out STDs. Those were all negative. We ordered autoimmune workup, which included the ESR, CRP, ANA, rheumatoid factor, anti-double-stranded DNA, anti-Smith antibodies, anti-SSA and SSB. They were all negative. So at that point, our differentials were pretty broad. We were thinking about, in addition to the eczema and the atopic dermatitis, we were also thinking about the chronic idiopathic urticaria and NSAID hypersensitivity, as well as the progesterone hypersensitivity. But given the fact of her history of cyclic nature of her symptoms, the concern for the progesterone hypersensitivity was pretty high. So what we end up doing, we sent her to the allergy immunology for the further workup, where she underwent a intradermal progesterone testing. And here's the picture of her test, which shows that she had a blood formation at 0.5 milligram per milliliter, which meant that it was positive for that. So usually the treatment for this situation is like, first line, we have to give antihistamines or steroids, but she had already taken them. And we could also use the OCPs. But the problem here was that given the history of no relief with the antihistamines, we couldn't use that in her. And given the history of severe migraines, we also couldn't use that, the OCPs in her. So after discussion, we offered her omalizumab, and she has been responding pretty well to it, and no flares, nothing right now. So the key learning points from here is that progesterone hypersensitivity is a rare dermatitis that can occur in response to the endogenous as well as exogenous progesterone. And it can be misdiagnosed, especially if the menstrual cycles are irregular. Therefore, thorough history taking is crucial for the diagnosis. And currently, there are no well-defined, universally agreed upon diagnostic criteria, and it still remains a diagnosis of exclusion. A multidisciplinary approach is required for a successful treatment. The treatment includes antihistamines, oral contraceptive pills, steroids, omalizumab, progesterone desensitization, as well as oophorectomy in some cases. So the ultimate decision depends upon the patient's preferences, what he or she wants to take, and then we can come up with the diagnostic and treatment plan. So that was pretty much about it. Thank you. And I'm open for the questions.
All right, questions, Dr. Javed, thank you for your presentation, and thanks to all our presenters and attendees. We'll take a 10 minutes break.